Okay, all right. So today we'll have our seminar on genetics. So, okay, proceed with the presentation.
Okay, can you see my slides?
Yes.
Okay. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Ahmad Abi bin Ahmad Yunus, and I will be starting our seminar today on genetics with the topic of molecular basis of genetics. So this is my outline presentation, introduction, chromosome, genes and allele, DNA, mutation, and also the importance of molecular genetics. So, introduction. For the introduction, I think it's important that we first look at some definitions that are related to our topic. So the first one is genetics. Genetics is the study of heredity and the mechanisms by which genetic factors are transmitted from one generation to another. And then for molecular biology is the branch of biology that concerns the molecular basis of biological activity in and between cells, including molecular synthesis, modification, mechanisms, and interaction. And then for molecular genetics is the study of molecular structure of DNA, its cellular activities, and its influence in determining the overall makeup of an organism. Okay. So the central dogma of molecular biology. So the central dogma of molecular biology is basically an explanation of the flow of genetic information within a biological system in a living organism. So there's a few key steps in this central dogma. The first one is the DNA replication, whereby DNA makes a copy of itself, and then DNA transcription, whereby DNA is transcribed into RNA, and then translation, whereby RNA is translated into a functional protein. Okay, next, chromosomes. So chromosomes are fine thread-like structures of nucleic acids, DNA, and protein found in the nucleus of the cells. It carries genetic information in the form of genes, and one chromosome consists of 2 chromatids and 1 centromere. So if you look at the picture, you can see that one chromosome has 2 identical chromatids. So one is an exact copy of the other, and each contains 1 DNA molecule. So the centromere is the constricted point of the chromosome, and it divides the chromosome into the short arm and the long arm. The short arm is known as the P arm, and the long arm is known as the Q arm. And the DNA molecule is a long string-like DNA molecule formed into a compact structure by proteins called histones. So histones help to supercoil the DNA to form the structure of the chromosome. Okay, next on the human chromosome. The human chromosome, human cells have 46 chromosomes, and 22 pairs are autosomes. One pair is allosome, or also known as the sex chromosome, and both chromosomes of each pair carry genes which control the same inherited characters. Okay. Next for the genes and the allele. So a gene is a segment of DNA that carries the genetic information which codes for a specific protein. So if we can look at the picture above, so the gene that encodes for the color of a flower is located in one segment of the chromosome. And this segment of the chromosome is known as the locus. So for the allele are basically two genes, genes that are found at the same locus. And they control the similar characteristics. And the types of allele, they can either be dominant or recessive, meaning to say that it can exist in 2 conditions, whether the allele inherited can either be dominant or recessive, and then it can be inherited in a homozygous pattern or heterozygous pattern. Homozygous pattern meaning to say that both alleles have the same type with either dominant or recessive, or heterozygous where the allele have one dominant and also one recessive allele. Okay, next. And then we're moving on to the DNA. So the DNA consists of a pair of chains of sugar phosphate backbone linked by pyrimidine and purine bases. If we're looking at the single nucleotide structure, we can see that the nucleotide has three components. One is the phosphate group, one is the sugar, and in case of DNA, it will be the deoxyribose sugar. And then the third part is the nitrogenous base. For example, in this picture is adenine. So the nitrogenous base are the purine and the pyrimidine bases. For the pyrimidine bases are cytosine and thymine. Meanwhile, for the purine are guanine and adenosine. The arrangement is of the DNA is always in the form of double helix. So there will be two sugar phosphate backbones coiled along each other, and the direction of the sugar phosphate bone is anti-parallel. So one will be in the direction of 5' to 3', and then the one will be in the direction of 3' to 5'. The 5' end is the one with the phosphate group, and the 3' end is the unbounded hydroxyl group of the sugar. Okay, next. This is just a picture I found. Okay, next, for the function of DNA, the two main functions of the DNA is replication as well as the transcription. So replication is important to pass the genetic information into the progeny, either the daughter cells or for the offspring. And then the transcription, DNA will serve as a source of information for the cellular synthesis of proteins. Okay, now we're going to look into replication process. So first of all, replication will take place, will first begin when by the help of an enzyme known as helicase. So the function of helicase is to unwind the double-stranded DNA. So you can see the helicase is the purple one that's not moving in the picture. So the helicase will unwind the protein, and then these yellow little like marbles known as single-strand binding proteins will act to stabilize the unwinded DNA and prevent it from rewinding. Okay, after helicase and the SSBP have done the job, a primase will add a primer, RNA primer at the promoter region. At the promoter region. And then after RNA primer has been added, DNA polymerase will attach itself to the RNA primer and continuously add nucleotide bases to the growing to the strand. So an important point to take note is that the reading is always in a 3' to 5' direction. Reading is 5' to 3' direction. However, the synthesis is done from a 3' to a 5' direction. So the strand at the top is also known as the leading strand because the synthesis of the DNA is done in a continuous manner, because the RNA polymerase in this condition, it can continuously add the bases without stopping, because it's in the correct direction. However, in the bottom strand, it is known as the lagging strand because the nucleotide bases are added in fragments. This is because the direction of the lagging strand is in a 3' to 5' direction. So in this condition, the RNA polymerase can only read the DNA polymerase can only read the sequence in fragments. Dia akan baca sikit-sikit. So what happens is also similar. So the first one is the primase will add the primer, and then DNA polymerase will add the bases. But after that, the DNA polymerase only adds the bases to a certain point, and then the RNA the primase will move upwards. Dia akan ke atas. And then tambah lagi DNA polymerase. Okay, so I hope that makes sense. And then after that, at the end, the result will be two new DNA strands. And the nature of these DNA strands are semi-conservative because you have one strand that is from the old DNA, the parental DNA, and then you have one strand which is the newly synthesized one. Okay, so I hope that makes sense. So this is just a summary. Oh yeah, I also forgot to mention, in the lagging strand, after the after DNA polymerase has added the base pairs, an exonuclease will remove the RNA primer, and then the DNA ligase will add the fragments to close the gap between the the DNA ligase will add base pairs to close the fragments between the Okazaki fragment. Okay, so this is just a summary. Okay, so after another function of the DNA is also for the process of transcription. So transcription is a process by which information from a genetic sequence in DNA is converted into mRNA. So the difference between transcription and replication is that transcription only involves a certain genetic sequence because we only want the cell only wants to encode for a specific portion of the gene to encode for a specific protein. It doesn't involve the whole DNA. So the first step in transcription is RNA polymerase, the purple thing here. It will bind to the promoter region with the help of transcription factor. So when it binds to the promoter region, it will unwind the DNA. And then after the DNA has been unwinded, it will produce two separate strands. One is the coding strand and one is the template strand. Like I've mentioned before, because reading is done in a 3' to 5' direction, so the template strand will be the one that is used for the synthesis of the RNA, and the synthesis will be done in a 5' to 3' direction. So after the RNA polymerase has unwinded and the synthesis of RNA has been initiated, there will be elongation of RNA until it reaches the termination signal. So when it reaches the termination signal, the RNA polymerase will dissociate from the DNA, and then the DNA will rewind again, and there will be a production of an RNA transcript. So the RNA transcript is although the RNA transcript has been produced, it is still not ready to be translated into a protein. So it will undergo a few modifications. So these are known as the post-transcriptional modification. So there's 3 modifications that are done. The first one is addition of a cap at the 5' end, and then there will be polyadenation at the 3' end. So there will be a poly-A tail, and then there will be removal of introns by splicing. The purpose of addition and addition of a cap and a tail is to ensure that the mRNA is stable, and the introns are removed from this immature mRNA because the introns are the intervening sequence. They are not involved in the they do not have the genetic sequence that encode for a protein, so they are not involved in the translation. So in the end, you have a spliced mRNA with a cap and with a tail. So this is the mature mRNA that is ready to be translated. So after the mRNA has been translated, it will be exported out into the cytoplasm to be translated, because in the cytoplasm is where you can find the ribosome. In the nucleus, there's no ribosome. So ribosome is important in translation. Okay, before we go into translation, I just want to quickly go on the codons. So a codon is a sequence of 3 DNA or RNA nucleotides that corresponds with a specific amino acid or stop signal during protein synthesis. Every 3 nucleotide represents a single codon coding for a particular amino acid. Okay, so one important point to take note is that one codon, they only encode for one particular amino acid, but one amino acid can be encoded by more than one codon. For example, like phenylalanine, it can be encoded by UUU or UUC, but UUU will only encode for phenylalanine. Okay. Okay, next, now is the translation process. So translation is a process of decoding an mRNA and using its information to build a polypeptide or chain of amino acids. Okay, so if you're looking at this diagram here, you can see at the top you have the mRNA, which has the AUG, which is the start codon, as well as the UAG, the stop codon. And then you also have the ribosomal units, the large and the small units, and you also have the tRNA. A tRNA will carry itself, will be carrying an amino acid. So for example, at the start codon, they will carry the methionine. And the nature of the tRNA is that they will have an anticodon, which is complementary to the codon that is found on the mRNA. So during initiation, there will be formation of the initiation complex consisting of the large and small ribosomal units, the mRNA itself, and then the tRNA that has the amino acid group attached to it. And then after the first amino acid is attached, the ribosome will move to the next codon. So it will read the codon one by one, and when it reads the codon, when it moves to the next codon, another new tRNA will enter the complex, carrying a specific amino acid, and then this amino acid will the amino acid from the previous codon, for example methionine, will attach itself to the amino acid on the second tRNA, and afterwards there will be elongations, meaning to say that it will continue, the ribosome will continue to move, and then tRNA will continuously be added, and then the tRNA will also bring the amino acids, and then there will be the elongation of the polypeptide chain until the ribosome reaches the UAG, the stop codon. So when it reaches the UAG, the stop codon, a release factor will bind to the complex and cause the dissociation of the complex. So the polypeptide is now complete and will be released, and then the translational components will be recycled. Okay. And next, mutation. Okay, for mutation, mutations are permanent changes in the DNA. Mutations that affect germ cells can be transmitted to the progeny and may contribute to inherited diseases. Mutation can affect a single nucleotide, a gene sequence, or even a whole chromosome. And causes of mutation, for example, environmental factors such as UV light, chemical carcinogens, ionizing radiations, or even viral infections, and also replication errors such as during meiosis or mitosis, and there is error during DNA repair. Okay, next, for the classification of mutation, it can be classified into mutations affecting the total number of chromosomes. So that will be genome mutation. Mutations altering the structure of individual chromosomes, that will be chromosomal mutation, or mutations that alter individual genes. So that will be gene mutation. So the first one is genome mutation. In genome mutation, there will be a loss or gain of whole chromosome. Also, condition is also known as aneuploidy. So in aneuploidy, for example, in monosomy, there will be a loss of a whole chromosome. For example, in the Turner syndrome, this patient lacks one sex chromosome. So the karyotype will be 45XO. For example, in the trisomy, in this case, the patient will gain one extra chromosome. For example, in this patient is trisomy 21, Down syndrome. The patient gains one extra chromosome at chromosome 21. Okay. And next is the chromosomal mutation. Chromosomal mutation occurs when there's a rearrangement of genetic material, and it will lead to visible changes in chromosomal structure. The first one is deletion. So you can see that there's a deletion of a segment of the chromosome from ABC turns to AC, or duplication, where there will be a addition of a genetic segment in the chromosome. Inversion occurs when there's a reversal of the organization or the sequence of the gene. So from ABC it turns into AED, or translocation occurs when there is a movement of a segment into a non-homologous chromosome. So when it should be ABCDEF, it turns into ABCJKL. Okay, and finally gene mutation. Gene mutation, there's three types of gene mutation: point mutation, frameshift mutations, and also trinucleotide repeat mutation. In point mutation, it results from the substitution of a single nucleotide base with another, and it may lead to replacement of one amino acid to another. So the three types of mutation are silent, nonsense, and missense. In silent mutation, the mutation has no observable effect on the phenotype. For example, in this one, you can see that thymine, cytosine is changed into thymine. However, at the end, the product is still lysine, so it's no effect, because we know that one amino acid can be encoded by many codons, right? In nonsense mutation is a mutation that changes amino acid into a stop codon. In this case, UAG is the codon, and the missense mutation is a mutation that changes codon of one amino acid to another. So missense can be divided into conservative or conservative. In conservative missense mutation, the amino acid that is produced is different. However, it has similar characteristics to the original amino acid. For example, it is either the characteristic maybe like both are hydrophilic or both are hydrophobic. But in non-conservative missense mutation, it will produce a completely different an amino acid with completely different characteristics. Okay, next is the frameshift mutation. Occurs when there's an insertion or deletion of one or two base pair. The reading frame of the DNA strand will be shifted. For example, of the diseases are cystic fibrosis and Crohn's disease. If you look at the picture on the right, you can see that, for example, in the normal translation, it will be read as ACG. But if there is an addition, for example, if there's addition of a base pair, instead of being read as ACG, it's now read as CGA. Or if there's a deletion, instead of being read as ACG, it is now read as GAG. Okay, and finally, the trinucleotide repeat mutation occurs when there is amplification of three nucleotide sequence. It will cause defect in the protein encoded by the gene, change the regulation of gene expression, produce a toxic RNA, or lead to chromosome instability. For example, in this case, if I'm mistaken, this is in Huntington's disease. There is a repeat trinucleotide sequence of a CAG. Instead of just having one codon of CAG, there's three. It's not necessarily in other diseases. It's not necessarily three. It can be more. So it's not necessarily 3 times. Okay. Finally, for the importance of molecular genetics, molecular genetics can give us insight on heredity, genetic variations, and mutations, not just in humans, but also in other living organisms such as viruses or bacteria. And then number 2 is can be used for the diagnosis and management of genetic disorders. And finally, we can use it to provide counseling for patients in the carrier state. Okay, that's all from me. Any question?
Okay, any question from the group? Because semua pengsan dah semua. Okay, presenter, I have one question for you. You told us about the translation and so on and so forth. You mentioned about mRNA. So what is the latest issue involving mRNA? Can you highlight to us?
I think doctor is talking about the mRNA vaccine, right?
Oh, yes.
So for the mRNA vaccine, mRNA vaccine is a very new technology in vaccine development. So the COVID-19 vaccine will be the first vaccine that will implement this technology lah of mRNA.
So if you see your presentation just now, so mRNA is not first a few things, because people have been saying if we give mRNA vaccine then it will change your DNA. It doesn't happen because mRNA doesn't code for DNA, isn't it? So mRNA codes for protein.
Protein, yeah.
Codes for protein. So mRNA codes for protein, and mRNA, so the problem previously, so mRNA, the idea about using mRNA has been there for many years already. It's not new. Even I think for the past 10 years, people have been thinking, scientists have been thinking about using mRNA. They were trying for mRNA during the first SARS-CoV infection, the first SARS. They were trying to do using mRNA. So the problem with mRNA is that after it codes for one protein, we then lose the mRNA. It codes for when it's translated into one protein, then we lose the mRNA. So they have the problem of how to use just a single vaccine which can code for enough protein to actually produce enough antibody to fight the infection. So this has been the problem. So, and luckily, alhamdulillah, because in around 2019, 2020, they have managed to solve this problem. They have managed to solve this problem where they can create a more stable mRNA. So the good thing why this time we were able to produce COVID vaccine very early, less than 1 year, we managed to produce vaccine. Why? Because from the very beginning, you remember COVID was first found in China in end of November. Actually, China is very advanced. Actually, kita pandang rendah pada dia. Actually, they are very advanced. So they have managed even by mid-December, they have already got the coding, the DNA sequence, the DNA sequence of the COVID, of the SARS-CoV-2 virus. So by December, and that is why we were able to monitor the changes in terms of the mutation and so on and so forth of the SARS-CoV-2, because we have been monitoring the DNA of the genome of SARS-CoV-2 very closely. And the moment you have the genetic material, the genome coding, you can easily create the mRNA vaccine. So this is the idea behind it. So that is why we were able to get mRNA vaccine quite early as compared to other types of vaccine. Okay, all right, proceed. If there's no question, then let's proceed.
I think no question.
Okay, next presenter.
Can anyone see my slide and hear me?
Yes.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I'll be proceeding with the autosomal disorders. So my name is Rudin, matric number 1819478. So this is the outlines of my presentation. The first we will start with the classification and definition, and then we move to the autosomal dominant, and lastly we'll move to the autosomal recessive. So the first one, basically the autosomal disorder, it is based on the observation of a scientist named Gregor Mendel with his piece. So Gregor Mendel, the originally of his idea is that through the Mendelian inheritance, in which that every trait that is manifested by the offspring is controlled by a single gene that is inherited by their parents, and this gene may be dominant to one another. So what happened when one of these genes is mutated, just like I presented before. So this is called as Mendelian disorders, in which there is mutations or defects in the single gene following one of the three patterns of inheritance, which is the transmission pattern. So as you can see, the transmission patterns, it consists of three patterns. But for my presentation, I'll be covering about the two, which the last three will be covered by my colleague. And for autosomal dominant and autosomal recessive are basically defined as the mutations that involve the single gene in autosomal chromosome, which means that the chromosome, it is a non-sex chromosome. It doesn't involve the X and Y chromosomes, as you can see at the karyotype at the picture below. So it involves the mutation at the genes of chromosomes 1 until 22, but does not involve the X and Y chromosome. So, okay, so that is generally the definition. So we move to the autosomal dominant, the first one. So autosomal dominant defined as the presence of one abnormal gene on one of the autosome, which is, as I mentioned before, chromosome 1 until 22. So what is that? Is that in this autosomal dominant, one mutated genes, because in one chromosome consists of two genes. In one chromosome pair consists of two genes. So one gene is enough to have the patients to be affected with disorders that is listed under the autosomal disorders. So as you can see at the picture here, we have the affected father with the mutated genes on his chromosome, and he married to the unaffected mother, and the offspring, it is, we say that in 50% of the offspring will have the disorders same as his father. So the baby is said to have one chance in two of having the diseases, and the recurrence will be 50% of each birth. And this autosomal dominant inheritance, it is in vertical transmission, which means that it is from parent to the child. And then it manifests in both homozygous and heterozygous state, which means that if the let's say that if the genes, there are two mutated genes, it will also manifest the disorder. If it is one gene mutated, it will also manifest the disorder. So we say that it will manifest in homozygous and heterozygous. And then males and females are equally affected because it involves only the autosomes. And then however, when the patient came to the doctor, usually there is no history of an affected family member. And this is due to four reasons. The first one is the new mutation. New mutation, or we said as the de novo mutation, say that the mutation occur on the sperm and the egg of the parents. So which means that before embryo was formed, there is mutation in the sperm or an ovum. So we say it is a new mutation. And the second, incomplete penetrance. So incomplete penetrance, you can see at the image on the right below. So you can see that at the first generation, there is affected male, and then he married, and then the offspring is affected, the male. However, because this is said that this male is actually affected. However, there is no evidence of any phenotypic manifestation that say that this individual has the autosomal dominant inheritance. So when he doesn't express the manifestation of the phenotypic manifestation, so when he got married to the unaffected pair, then suddenly his child got the disorder the same as his siblings or his grandfather. So it is said as the incomplete penetrance. And then for the variable expression is when individuals with the same autosomal dominant disorders, it manifests the disorders in varying degrees. Some might be mild, some may be severe. And then for somatic mutations, somatic is basically the spontaneous mutation. The difference between somatic and new mutation is that this somatic mutation, the mutation occurs in the cells that forms the embryo, which means that it doesn't occur in the sperm or an egg, but it occurs in the cells that will form the embryo. So that we call as the somatic mutation. And then we move to the examples of autosomal dominant disorders. So basically, there are a lot under this, but however, today I'll be discussing about only two, which is Marfan syndrome and neurofibromatosis. And then, okay, we move to the Marfan syndrome. So generally, Marfan syndrome is an inherited systemic connective tissue disorder. So how does this syndrome occur? So it started with the mutation in fibrillin 1, which is FBN1 locus of the fibrillin gene. So at the long arm of the chromosome 15. So fibrillin gene is said to encode the extracellular matrix of protein fibrillin 1 that functions to form the microfibers in order to give the strength to the connective tissue, to the flexibility and strength of the connective tissue. And also this gene is proved to control the growth of the cells. So when this mutation occurs, there will be derangement of the elastic fiber deposition, as well as there will be uncontrolled growth of the tissue. And Marfan syndrome, the worldwide incidence is around 1 in 10,000 live births, and it generally manifests, we call it as cardinal manifestation, known as the pleiotropy. Pleiotropy means that one genetic mutation, one gene that is mutated can manifest a lot of systemic disorders. So usually this cardinal manifestation involve the three main, which is the first one skeletal, the second cardiovascular, and the third one is ocular, which is around our eye. And then, okay, we move to the clinical features. The first one in skeleton, we can see that the patient, especially in child, presented with the pectus carinatum, which is the outward bulging of the sternum, or pectus excavatum, which is the inward bulging of the sternum. So we can see upon the physical examination. And also the patient may have reduced upper segment to the lower segment ratio, which means that the upper segment is more longer compared to lower segment. And also there will be increase in arm span to the height ratio, which is around more than 1.05 times. And scoliosis is lateral curvature of the spine due to overgrowth of the connective tissue there. And Walker-Murdoch sign, the positive or the Walker-Murdoch sign. So Walker-Murdoch sign, you can see at the picture at the B. So basically, Walker-Murdoch sign, usually when we take our arm and then we circle our pinky finger and the thumb finger, and then we circle here. So basically, if it is overlap, so that means there is positive Walker-Murdoch sign. And then for the Steinberg sign as the picture of A. So as you can see, when the patient, they put their thumb at the palm, and then we will close our four fingers. So usually this thumb will not exist the ulnar border of the patient. However, in this patient with Marfan syndrome, it will exist just like at the picture. Okay, so the next will be the cardiovascular system. The patient may have mitral valve prolapse with or without regurgitation, and then presented with the aortic aneurysm and dissection. This one can be life-threatening to patients, especially in children, and eventually due to a lot of manifestation in the cardiovascular system, it may lead to congestive heart failure. And then for the ocular system, patient may present with ectopia lentis. Ectopia lentis is the dislocation of the ocular lens, and also early and severe myopia, which means that the patient has nearsightedness. They cannot see far, but can see at near surrounding. And then the patient may have flat cornea, hypoplastic iris, and ciliary muscle hypoplasia. And eventually, when it is severe enough, the patient may have glaucoma or cataracts. So done with the Marfan syndrome, so we move to the neurofibromatosis. Usually, the most common neurofibromatosis that is manifested by the child is neurofibromatosis type 1. And this is basically the tumor on the nerves. So how does this happen? So the pathophysiology says that there is mutations in the Neurofibromatosis Type 1 NF1 gene at the chromosome 17. So this NF1 gene, it functions as tumor suppressor gene. So tumor suppressor gene, we know that it prevents the cells of growth. So when the cells of growth cannot be controlled, there will be resulting in the tumor. So worldwide incidence is around 1 in 3,000 live births. And clinical diagnosis. So clinical diagnosis, usually when the doctor wants to diagnose the patient having the neurofibromatosis type 1, it has around several criteria in which it must be 2 or more. These criteria must be positive in order to diagnose the patient with this disorder. So the first one would be, I'll be explaining later on the next step. I will mention this. The first one is there must be more than 6 caveolate macules that is more than 5 millimeter in pre-puberty child or more than 50 millimeter in post-puberty child. And the second, the patient must be presented with axillary or inguinal freckling, or the patient may be presented with 2 or more iris fixed nodules, and then 2 or more neurofibromas or 1 plexiform neurofibroma. And then osseous lesion. Osseous lesion is basically the bone disfiguration, such as in sphenoid dysplasia. And then optic gliomas. Optic gliomas, we may diagnose through MRI, in which there is a thickening of the optic nerve, and also when the patient have first degree relative with the neurofibromatosis type 1 mutation. Okay, so this one is the clinical features of neurofibromatosis that I've been list earlier. So this is the picture of the patient presented with that manifestation. So we see at the axillary freckling. So you can see that the patient's armpit is scattered with the freckles. So the freckles is usually 2 to 3 millimeter in diameter, and usually a patient as early as 3 years old can manifest these freckles. And then iris fixed nodules, you can see that there is nodules in the iris. So basically this one is hematomas of within the iris. And then cafe outlet spot. So basically cafe outlet spot is the hallmark of the neurofibromatosis type 1. So basically if patients have neurofibromatosis type 1, almost all patients will have the cafe outlet spots. And generally, even the baby that was just born can have these spots. So eventually the number, the size, and also the pigmentation will increase when the child grows older. And then the neurofibroma usually occurs mostly in adolescent. And you can see that there is restriction and somehow it is rubbery inconsistency, and it has that purplish discoloration on the underlying skin. So that is about neurofibromatosis. So next we move to the autosomal recessive disorder. So autosomal recessive is defined as the presence of the both abnormal copies of gene. Just now autosomal dominant only want to manifest the disease. However, for autosomal recessive, we need both genes to be mutated in order to manifest the disease. Okay, so as you can see at the diagram, just like I mentioned, the father usually in the autosomal dominant, there is no carrier, but in autosomal recessive, there is carrier, in which if the patient have only one mutated gene, the patient is considered as the carrier. But however, if the patient has 2 mutated genes and the disorders is manifested, then we call it as affected. Okay, so it is said that when the father and mother that is a carrier married, they will produce a child, and the child may have 25% risks of getting the diseases. So usually this autosomal recessive inheritance, it is in horizontal transmission. Horizontal means that the carrier with the carrier. So the carrier and the carrier. So basically they need to be together in order to manifest that 2 affected genes. So that is not normally the horizontal transmission, unlike the autosomal dominant, which means they only have to carry only one gene. So it is vertical transmission. And then, okay, so autosomal recessive manifests in homozygous state only. It is not heterozygous. and males and females are equally affected, and usually the risks of the autosomal recessive disorders increase with consanguineous marriage, which means especially in family that especially in the first cousin union. Like you can see that here at the diagram below, the grandfather has the mutated gene, and then his son will also have the mutated gene, and his daughter, and then they married to other. Eventually their sons, which means that they are cousins. So their cousins both married. However, they have the trait. They have the one mutated gene. So when horizontal transmission occurs, so the offspring will get affected. So that is meant by the risks in the consanguineous marriage. So okay, so under the autosomal recessive disorder, there also are a lot of diseases, and I'll be discuss about two, which is sickle cell disease and cystic fibrosis. Okay, so the first one is sickle cell disease. So sickle cell disease is
The common name in Malaysia should be thalassemia. You should have discussed about thalassemia, but that's fine.
Because thalassemia will be discussed in hematology.
Okay, alright, fine.
Okay. Okay. So sickle cell disease occur when there is mutations that substitute the timing for adenine in the cis codon of the beta globin gene, which means that from GAG to GTG in that cis codon. And then because of the substitution, instead of coding the glutamine protein, it will code for the valine. And the hemoglobin that is formed, it has a physical properties of forming a polymer, which means that it can crystallize whenever there is whenever it is in the oxygenated state, or we call it as in the oxygen tension state. What happens is that eventually when it is it will be decreased in solubility, it will increase in viscosity, it will become like a sickle shape, but it can be reversible when there is enough oxygen in the body. However, when this recurrence of the sickling process occurs, eventually the membrane of the hemoglobin will be damaged, and hence it will lead to the permanent sickling process, which the hemoglobin, which the red blood cells, will stay in a sickle shape. And this can cause the problem because this sickle shape has a tendency to adhere, especially at the microcirculation, and it can block the microcirculation to cause a lot of complication after that. So common clinical conditions is the first one is HPSS, which is we call as the sickle cell anemia. This one is the most common that occur in patients with sickle cell disease and the most severe form. For HPS is only the sickle cell trait, which means that only one beta globin gene is affected. And then for clinical features of the sickle cell anemia, so usually patient that came with sickle cell anemia is very like life-threatening symptoms, very severe. So the first one, fever and bacteremia. So this one is medical emergency, especially in infants around 6 months old, because in infant with sickle cell anemia, they tend to have a splenic dysfunction, and this can cause the abdominal immune response. So if fever occur in this infant, so we have to admit this patient to the hospital immediately. And usually the organism then can infect the patient because there is low in immune response is the encapsulated organism, which is Streptococcus pneumoniae, HIV, and Neisseria meningitidis, and this can cause the bacteremia, which is very worse. And the next is the aplastic crisis. Aplastic crisis usually triggered by the parvovirus B19 infection, because this parvovirus B19 infection, it will limit the production of the reticulocytes, and hence there will be profound anemia. So the patient may be presented with pallor, fatigue, and tachycardia. And then in splenic sequestration, so in splenic sequestration, usually the patient may have a rapid enlargement of the spleen, and this can cause left-sided abdominal pain and distension, and also it is very life-threatening because it may show signs of hypovolemia, because in this patient there will be, we call it as blood trapping at the spleen, and can cause the profound anemia. And then also in this patient, because the spleen is some sort like dysfunction, it can increase the infection risks in this patient. And then the third one is the fourth one is the sickle cell pain. Sickle cell pain or it is manifested based on the acute vaso-occlusive pain. Vaso-occlusive pain will manifest the sickle cell pain. So basically, from the pathology, we know that when there is blood trapping at the microcirculation, it will block the microcirculation and can cause the tissue ischemia. So that thing will cause the pain to the patient. And usually for the first thing to manifest is dactylitis. Dactylitis is known as the hand-foot syndrome, in which there is symmetrical or even unilateral swollen and pain at the hand and the foot of the patient, of the child. And also in adolescent, we can see that the child have priapism. Priapism is unwanted painful erection of the penis, and this is caused by the venous stasis at the corpora cavernosum. And for the hemolysis crisis, because there is reduced acute accelerated of hemoglobin, there is a lot of hemolysis and so on. So there will be a hemolytic jaundice. And for neurologic complications, because there will be microcirculation blockage, especially at the brain, so it can cause overt stroke or silent stroke. For overt stroke, the patient may present with seizure or even paralysis. And then for silent stroke, usually the patient may have trouble in concentrating in the school, or trouble for concentrating like to write or something. So that is the symptoms. And then we move to the cystic fibrosis. So cystic fibrosis occur when there is mutation of the cystic fibrosis transmembrane conductance regulator CFTR gene at the long arm of the chromosome 7. So this gene will encode for the CFTR protein, which is mainly found at the respiratory tract, at the pancreas, at the GIT, as well as the sweat glands. And the function of this protein is to regulate the movement of chloride and sodium ions across epithelial membrane. So you can see at the picture where the chloride will be transported out to the mucus through the functional CFTR protein. So this chloride will draw in the water to make the mucus more watery, to make the mucus thin out, more diluted. So what happens when there is mutation of this gene? There will be dysfunctional of the protein CFTR. So this will lead to the defective in ions transportation, and hence there will be increase in secretion of the chloride. There is no chloride in this mucus, and also increase in reabsorption of sodium and water. So when chloride cannot draw in water into the mucus, so the mucus will be thick, and this thickness of mucus will somehow makes it stickier, and the bacteria can stick to the mucus. So it may promote the infection and inflammation to the patient. So because there is increase in reabsorption of sodium and water, the sweats of the patient will become salty. So basically when the patient's parent kiss the child, they will feel like the sweat is very salty because of this. And then for the clinical features of cystic fibrosis, there are 4 systems that involve. The first one is respiratory. So when, just like in the pathogenesis, as I mentioned, because the mucus is stickier, the microorganism can stick to the mucus, and this can cause the recurrent infection, especially from the Streptococcus pneumoniae, from the HIV, from the Pseudomonas, and it can cause the bronchiectasis and abscess formation. And this, the patient may be presented with productive cough, papaya sputum, and also shortness of breath. And then in exocrine, which is at the pancreas, there will be insufficiency of pancreas, in which there will be deficient in the lipase, in the enzymes, in all of the enzymes such as lipase, amylase, and also protease. So when there is deficiency of this enzyme, so there will be maldigestion. Every food that the patient takes, the food cannot be absorbed into the patient's body. Hence, there will be malabsorption of the fat, of the of the fat of the protein, and hence it will lead to the malnutrition of the patient, and consequently it can lead to failure to thrive. And also because there is insufficiency of the enzyme in pancreas, the patients may develop diabetes mellitus. However, this DM is developed in the later of life. And also in GIT problem, especially in neonates, there will be meconium ileus. Meconium ileus is basically the thickening of the meconium, and this can cause the intestinal obstruction. So the patient may present with abdominal distension and abdominal pain. And then for the steatorrhea because of the malabsorption just now, because so the patient, when the patient passes the stool will be oily. And then for distal intestinal obstruction syndrome, for this syndrome, it is usually in adolescent. So there will be obstruction of the intestine. So the patient will complain of the abdominal distension and hard to pass the stool. And for reproductive system, usually in males, there will be infertility due to failure in development of Wolffian structure, Wolffian duct. So the patient may have azoospermia, which means there is no sperms. And also the patient may delay in puberty. So I think that's all from me. This is my references. And with that, thank you.
Okay. Any question? Any question to the presenter? Okay, what sort of question that we usually these sort of cases we can bring for OSCE. So OSCE, sometimes we can draw the hereditary. So from father apa semua kita draw hereditary tree, and then we ask you what sort of hereditary is this? Is this autosomal dominant, recessive, or is it sex linked? And then we can ask you like name 2 common diseases and so on and so forth. Okay. All right. Ada question? Tak ada. How many presenters ni?
Another 2.
Another 2. Okay. All right. Let's proceed.
Hello, Assalamualaikum. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Mrna Vaccine, and today I'm going to present about sex-linked disorder. So I will start my presentation with sex chromosome, and then sex-linked inheritance pattern, and then sex-linked disorder. So for sex chromosome, it is a 23rd pair of human chromosomes. As we know, human consists of 22 pair of autosome and 1 pair of sex chromosome. And this sex chromosome participate in sex and characteristic determination, XX for female and XY for male. And X chromosome is usually larger than Y chromosome, and it carries more gene as compared to Y chromosome. So for the sex-linked pattern of inheritance, this pattern of inheritance also follows Mendelian pattern of inheritance, where there is three law in the Mendelian inheritance pattern. As for X-linked inheritance, the sex-linked refer to gene located at one sex chromosome. So the gene located at X chromosome, while the gene for the Y-linked inheritance located at Y chromosomes. And both genders are affected in X-linked inheritance, and only males are affected in Y-linked inheritance because presence of Y chromosome. And for X-linked inheritance, usually the affected father will transmit the disease to daughter only, and the affected mother transmit disease to son and daughter. While for the Y-linked inheritance, the transmission only occur from father to son only, but this Y-linked inheritance is extremely rare. So for X-linked inheritance, there are X-linked dominant and X-linked recessive. So for the first one is X-linked dominant. The gene controlling
the trait located on one of the chromosome is expressed. And males are severely affected because male has only one X chromosome as compared to female that has double X chromosome. But female will have less severe symptom because of X chromosome inactivation, but are commonly affected in general population. So in X-linked dominant, there is no carrier status, while in X-linked recessive, there is carrier status. And the trait will appear in every generation, as you can see in the pedigree diagram here. Okay, so in here you can see in the third and fourth generation, the affected father, usually all daughter will affected, like in this number 3 in this fourth generation, and no sons are affected. For heterozygous affected mother, you can see in the second and the third generation here, heterozygous affected mother will inherit 50% chance the disease to the children, while the homozygous affected mother will inherit 100% chance to the children. Okay, for the X-linked recessive, this X-linked recessive refers to the gene controlling the trait located on both of the chromosome in female and only one X for male. And the expression of this trait is higher among males because male has only one X chromosome. But for female, the most carriers are generally unaffected. But if the female is affected, it can only present with mild presentation. Okay, as you can see in the picture here, the affected father will inherit to all daughter, but the all daughter can be carrier, and no sons are affected. For carrier mother, there is chance of 50% to the sons will be affected, and there is chance of 50% daughters to be carrier. But this condition only applies if the carrier mother does not marry to affected father. But if the carrier mother married to affected father, there is chance of getting affected daughter as well. Okay, next is Wildling inheritance. These Wildling traits are extremely rare because usually it is associated with infertility. So these inheritance are rarely transmitted. And then only males are affected. So this is male to male transmission. Mutated alleles on the Y chromosomes are always passed on from the father to the son. Affected father cannot transmit the gene to his daughter because only Y chromosome, right? So next is sex-linked disorder. Sex-linked disorder refers to the genetic disorder caused by mutation of single gene located in sex chromosome. So there are either X-linked dominant disorder, X-linked recessive disorder, and Y-linked disorder. Okay, for the first one, X-linked dominant disorder, the most common is X-linked hypophosphatemia, or sometimes referred as hypophosphatemic rickets. This is due to mutation of phosphate regulating gene, PHEX gene, that stimulates fibroblast growth factor 23 that can cause phosphaturia. This fibroblast growth factor is important in metabolism and regulation of phosphate and vitamin D. Thus, if this fail to occur, there will be phosphaturia and then hypophosphatemia. So the characteristic for this disease are short stature, ricket of femur and tibia, tooth abscess, osteomalacia, bone and joint pain, as well as gait abnormalities. And then there is also decreased intestinal calcium and phosphate absorption. So there will be phosphaturia and then hypophosphatemia. And then there is also decreased renal phosphate reabsorption. As you can see in the picture, that is a picture of rickets for femur, and then a picture of tooth abnormalities. Okay, moving on to Incontinental Pigmentee. This is due to mutation of NEMO or IKBKG gene that will cause disturbance in skin pigmentation. And this disease sometimes associated with malformation of the eye, teeth, and skeleton. Incontinental pigmentee is more common in female if compared to male, and it is characterized by major presentation like vesicular and pigmented macular lesions. It can happen on the extremities or the trunk. And for the eyes manifestation, there will be strabismus. Strabismus is juling in Malay, and then congenital cataract, and then there is also retinal telangiectasia that is caused by blood vessels in the macula of the eye grow abnormally. And for CNS manifestation, there will be mental retardation and microcephaly and hydrocephalus. For oral manifestation, the child will present with malformed teeth. Okay. So for next disorder is Fragile X syndrome. Fragile X syndrome, also known as Martin-Bell syndrome or Marker X syndrome. This is due to unstable region on X chromosome contains abnormal number of DNA base pairs. It is the most common cause of inherited mental retardation or autism in children in sex-linked disorder. For the characteristic, usually the child present with mild cognitive and behavioral deficits, and then there is moderate to severe mental retardation. For the thing that we can observe is the child will have long, thin face, large ears, and prominent jaw, and also post-pubertal macroorchidism. So post-pubertal macroorchidism is the abnormal large testes after puberty. And then hand biting, speech disorders, and tactile defensiveness, and also difficulties in feeding and toileting. So you can see here in the picture there is many symptoms that can present with this syndrome. So next is Rett syndrome. Rett syndrome is a disorder that occur due to mutation of MECP2 gene that encodes protein for normal development of CNS system. And Rett syndrome is a neurodevelopmental disorder with typical degenerative syndrome and will exclusively affecting girls. For the characteristics, the females usually are normal at birth, but after first year of the life, the females can develop microcephaly and developmental regression and plateau. So she can often diagnose with autism by the first by the first time of life, but at the age of 2 years old, she can adopt a hand washing posture that is sign of developmental regression. Okay. And then there is disturbance of autonomic nervous system. There will be breathing irregularities and intestinal disturbance, and breathing abnormalities and seizures can also occur in this syndrome. Moving on to X-linked recessive disorder, there is the first common is color blindness. Red-green is the most common as compared to blue-yellow color blindness. So this red-green color blindness is due to mutation of all these three genes. And commonly, this mutation will affect photopigments of green or red cones of the eyes, but less commonly will affect blue or yellow color. So the characteristics, there are four. Due to anomaly, the yellow and the green color will look redder, as you can see in the picture here. And protanomaly, the orange, red, and yellow color look greener. Colors are less bright. Protanopia, the not working red cone cells, so the red color will look a little bit dark gray. And then deuteranopia, there is no working green cone cells, so the red color may look brownish yellow, and the green will look more beige. There is also other forms of color blindness like tritanopia. So, but this is less common in X-linked inheritance. Next is hemophilia. Hemophilia occurs due to mutation of factor 8 and factor 9 gene that make up coagulation factor 8 and factor 9. So there are two, hemophilia A, which is factor 8 deficiency. The cases reported is more than hemophilia B, and hemophilia B is factor 9 deficiency. So the characteristic is that the child will easily get bruised when crawling or walking, and there is also episodes of hematosis, which is the bleeding into a joint cavity, and episodes of epistaxis, which is the nasal bleeding, gum bleeding, and hematuria. And then there is also episodes of bleeding spontaneously after trauma, operation, or dental procedures, or can also occur after circumcision. So next is G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. This is due to defect in G6PD enzyme, which is an important enzyme in protecting red cells from hemolysis by reactive oxidant species. And this is most often affects male, and the triggering factors like infections, malaria and malaria infections, favavin and drugs like NSAIDs can cause the G6PD the acute G6PD attack. For the characteristics, usually the child is asymptomatic. Sometimes there is neonatal jaundice, and then there is episodes of intravascular hemolysis following triggers, like I mentioned before. And then there is feature of chronic hemolytic anemia like shortness of breath and jaundice. The next one is Duchenne muscular dystrophy. This is due to mutation of Duchenne muscular dystrophy gene. This dystrophy is non-inflammatory but progressive muscle disorder. So the patient can present with muscle weakness and wasting. And this primarily affects skeletal muscles which are used for movement. So the movement are affected, and cardiac muscles for heart. So the characteristics include mental deficits, developmental delay, gait abnormality, as well as loss of ampliation. So the picture here is a picture of sign of child with muscular dystrophy, also known as Gower sign. So this sign indicates weakness in proximal hip muscle. So he or she will use hands to push on legs to stand. Next is Wildling disorder. Okay, this disorder only affects male, but the transmission is rare due to male infertility in affected father. So the first one is retinitis pigmentosa. This is a rare disorder that involves breakdown and loss of cell on the retina, leading to loss of vision. So the patient can present with nyctalopia, which is night blindness, progressive loss of visual field that starts from peripheral field vision to central vision, and then photopsia, which is a condition that the patient see flash of light immediately. And then next is auricular hypertrichosis. This is also a rare disorder that involves growth of long and strong hair from helix of pinna of the ear and occur in excessive amount. So this can appear at birth and develop over time. So the characteristics, apart from the growth of the hair, can also present with dental abnormalities, defect of the ears, and photophobia. Okay. Any question?
Anyone? Hidup lagi ke semua? Kau pengsan Melaka dah?
Hidup, doktor.
Hidup lagi Okay, good. Okay, so again, okay, my question. What type of hereditary is G6PD deficient?
What?
G6PD deficient.
X-linked recessive.
Can a female get G6PD deficient?
Can, but most common in male.
So how can a female get G6PD deficient?
Because this disease is X-linked recessive. So usually carrier female can present with carrier status, but the affected father will marry to carrier mother to have G6PD in female daughter, G6PD daughter.
Another method. Is there any other method? If the mother is a carrier and then the father is normal, or if the child is heterogeneous, can the child get G6PD deficient? A female child get, if it's heterogeneous, can the child get G6PD deficient?
I don't know.
Okay, can is a very bad question. Usually, if we ask can, the answer is always can. So the answer is can. So there's something called Leonization. So Leonization is where the X-link, there's only one of the X that is prominent. The other one
activation.
yeah. So the issue with lionization is that the mutated the abnormal X chromosome is the one that is prominent. So this is why the patient, even though it is X-linked recessive, the patient may also presents with GCPD deficiency. Okay, all right, fine. Okay, let's go to the last presentation.
Okay, can you all see my slide?
Yes.
Yes.
So Bismillahirrahmanirrahim. I'm Najhan Raja binti Abdul Rahman. So today I'm going to be the last presenter for our seminar, and my topic today will be chromosomal disorders. Okay, what is chromosomal disorders? So it is an errors that occur in meiosis during the production of gametes that can lead to abnormalities of chromosome structure or number. So chromosomal abnormalities is divided into two, which are numerical abnormalities as well as structural abnormalities. So in numerical abnormalities, we have two categories, which are aneuploidy and polyploidy. However, our interest for today is regarding the aneuploidy, as all of these diseases, all of this syndrome is categorized under aneuploidy. So aneuploidy is a condition in which a person has one or few chromosomes above or below the normal chromosome number. Okay, the first one that we are going to discuss today is Down syndrome. Okay, Down syndrome is the most common autosomal trisomy and the most common genetic cause of severe learning difficulties. So the incidence of live-born infants with Down syndrome is around 1 in 650 patients. Okay, Down syndrome is usually suspected at birth because of the baby's facial appearance. Most affected infants are hypotonic, which means that the baby will have low or decreased muscle tone. And other useful clinical signs of Down syndromes include a flat occiput, single palmar creases, incurved fifth finger, and wide sandal gap between the big and second toe. So these are among the clinical features of Down syndromes. So in this table, the characteristic clinical manifestation of Down syndromes that the patient may manifest. And this table is took from Sunflower textbooks. Okay, next. How can there be an extra chromosome 21 in the Down syndrome patient? So the extra chromosome 21 may result from three cytogenetics, which are meiotic non-dysfunctions, which indicates 94% of trisomy 21 patients. The next one is translocations, which indicate 5%, and also mosaicism, which indicate 1%. Okay. In non-disjunction meiotic non-disjunction, most cases are result from an error at meiosis. So the pair of chromosome 21 fails to separate, so that one gamete will have two chromosomes and another one will have none. So when the fertilization occur of the gamete with two chromosomes of 21 give rise to a zygote with trisomy 21. So while for translocations, the most common translocation that with trisomy 21 trisomy 21 patient will have is Robertsonian translocations. When the extra chromosome 21 is joined onto another chromosome, and it is usually chromosome 14. However, it can also affect chromosome 15, 21, and 22, as well as 30. Okay, the next one is mosaicism. So in mosaicism, some of the cells are normal and some have trisomy 21. So this usually arises after the formation of the chromosomal normal zygote. And usually for mosaicism, the errors occurs after fertilization. Okay, this picture you visualize the explanation that I've told just now. Okay, how about the risk of recurrence? For non-disjunctions, it is related to the maternal age. After having one child of trisomy 21, due to non-disjunction mitic, the risk of recurrence of Down syndrome is given as in 1 in 200 to the according to the maternal age. Okay, the next one is translocations. So the risk of recurrence is 10 to 15% if the mother is the translocation carrier, and about 2.5% if the father is the carrier. Sorry. So if the parents carries the rare 2121 translocation, all of the offspring will have Down syndrome. And the mosaicism, the subsequent chances of having Down syndrome is only 1%. Okay, the risk factors for Down syndromes, the first one is older maternal age. As we can refer in this table that I took from pediatric protocols, the older the maternal age, the higher the incidence of having Down syndrome. Daughter, child. Okay, next is already having a child with Down syndrome, which means the recurrent risk, and as well as the parents who are carrier of genetic translocation, as I mentioned earlier. Okay, the next one, how to diagnose Down syndrome. So Down syndrome can be diagnosed antenatally using ultrasounds when we look at the nuclear fold thickness as well as the double bubble signs. Okay, in this picture, this shows normal nuclear fold thickness, and this one is the increased nuclear thickness in patient with ultrasound. Okay, this one is the double bubble signs, which indicate duodenal atresia that may be one of the clinical features for trisomy 21 patients. Okay, the next one is amniocentesis and chorionic renal sampling that can be sent for karyotyping and FISH. As well as if the newborn, we do blood sampling for karyotyping and FISH. Okay, these are the pictures of amniocentesis and chorionic villi samplings. So if amniocentesis, we need the needle to withdraw the fetal cells from amniotic fluid, while the chorionic villi sampling, we use the suction tube to remove the fetal cells from chorion. Okay. Okay, so basically the management for trisomy 21 is quite direct. So what we need to do is we need to give the adequate information to the parents regarding Down syndromes, as well as the short and long-term complications. And we need to counseling and to deal with the feeling of, usually the parents will have the feeling of disappointments, anger, as well as guilt of having trisomy 21 kids. And we can also share the local parent support groups of having trisomy 21 child, as well as to motivate them. And then every child with Down syndrome should have an access to an early intervention program as soon as possible. And the advice on potential recurrent risk and contraception for further for next pregnancy. Okay, these are the recommendations for medical surveillance for child with Down syndromes. It is to monitor the complication of the child with Down syndromes. Okay, moving on to the other numerical abnormalities. Okay, the first one is Edwards syndromes. So Edwards syndromes or trisomy 18 is the second most common, and the second most common autosomal trisomy, and occurring in approximately 1 in 8,000 live births. More than 95% of conceptors with trisomy 18 are spontaneously aborted in the first trimester. So these are among the clinical features of Edwards syndromes: clashed hands, dysplastic or malformed ears. Okay, the next one is Patau syndrome. So the Patau syndrome is rare compared to Edwards syndrome as well as Down syndromes. So it is occurs in 1 in 14,000 live birth, and it is usually fatal in the first year of life, and only 8.6% of infants survive beyond their first birthday. So these are among the clinical features for Patau syndrome patient. Okay, this table explains the differences between trisomy 30 and trisomy 18. So you can read later. Okay. Okay, the next one is Turner syndromes. Okay, usually more than 95% of Turner syndromes results in early miscarriage, and it is increasingly detected by ultrasound when there's fetal edema of the neck, hands, or feet, as well as a cystic hygroma may be identified. Okay, usually these are the clinical features of Turner syndromes. So patient with Turner syndromes is usually treated by growth hormone therapy as well as estrogen replacement for development of secondary sexual characteristic at the time of puberty. Okay, the next one is Klinefelter syndromes. So Klinefelter syndromes, the incidence are 1 to 2 per 1,000 live there's typo. Born males. So the clinical features of the Klinefelter syndromes are as follows. Okay. Okay, moving on to the last part, which are structural abnormalities. For your information, there are many structural abnormalities. However, today I am going to talk about two structural abnormalities, which are translocation as well as deletions. Okay, the first one is translocation. So when there is an exchange of material between two different chromosomes, it's called reciprocal translocation, and it is further divided into two, which are balanced and unbalanced. And usually patient with balanced reciprocal translocation, there will be no loss or gain of chromosomal materials, and usually the patient has no phenotypic effects, including cognitive difficulties. Sorry. Okay, the next one is unbalanced reciprocal translocation, which contain an incorrect amount of chromosomal material and often impair both physical and cognitive development. And it will lead to dysmorphic features, congenital malformations, as well as developmental delay. Okay, the next one is deletions. So deletions are another type of structural abnormalities when there is loss of part of chromosome, usually results in physical abnormalities and cognitive impairment. So one of the examples of these syndromes that have deletion is this one, Cri-du-Chat syndrome. So Cri-du-Chat syndromes is when there is a deletion occurs involve loss of the tip of the short arm of chromosome 5. And because most of the affected babies have high pitch moving cry in early infancy, and it is called as Cri-du-Chat syndrome because the baby will cry like a high pitch, like a cat meowing. Okay, I think that's all from me. Are there any questions?
I can't express how important Down syndrome is. Down syndrome you'll get for block exam, for professional exam. You'll definitely get Down syndrome. We have so many patients with Down syndrome. They can come for exams anytime and many times. There's so many things we can ask about Down syndrome. So I cannot express enough how important Down syndrome is. Okay, so Down syndrome, you do need to know what are the clinical features, how to diagnose, and so on and so forth. Another Najwa, ni kena ambil swab ke apa ni? The other thing is the other thing is kriducha. So kriducha literally means cry of the cat. Kriducha literally means cry of the cat. I've seen few of these cases. Memang bila baby tu cry, memang bunyi macam kucing tau. You know kucing malam-malam, sometimes dia nangis bunyi macam mana. So these babies, they cry like that. Sounds like cat, proper cat punya cry. So it's very interesting. So that's kriducha. And Edward syndrome also is quite common. I think in Susmec, we see Edward syndrome 2 to 3 cases per year. Patau syndrome we'll see around once per year. I think we see last few months back we saw one Patau syndrome died as well. Okay, all right. Any question? Any question? Clear semua? Fine, it's already 5. I still need to do my rounds before I go home. So I hope you guys understand. The topic is quite a lot, especially first presenter kan. That's the heaviest lah. You start with the heaviest punya presentation, but that's fine. That's okay. So I hope you guys understand, have an idea about it. Obviously, many of the diseases you won't actually see, but again, hemophilia, Down syndrome, Edward syndrome, those are among the cases that you may see in your exam. And hereditary tree, those are the things that you may see in exam as well, in OSCE and so on and so forth. Okay, all right, let's end our session with Tasbih Kafarah Surat Al-Nas.
Thank you, Doctor.
Thank you, Doctor.
Yes, I go.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.